of the Tunisian Association of Pediatric Surgery, and I want to thank so much Professor Samah for this awesome meeting, and I'm really honored to introduce the next speaker, Professor Retrosi Giuseppe, who is a well-known pediatric surgeon working in Canada. He also trained in many countries, including Italy, United Kingdom, and had missions in Eritrea and Nepal. Mr. Retrosi, Dr. Retrosi will speak about a very important topic, esophageal atresia and tracheoesophageal fistula management. This topic is interesting for many specialties, including an ICU, pediatrician, pneumologist, gastroenterologist, pediatric surgeon. So that's why we will listen carefully to Professor Giuseppe. Professor Giuseppe, the mic is yours.
Thank you for the professor. Doctor is enough. And thank you so much for the invitation to speak to you. I also had the pleasure to meet some colleagues from Cairo at the last IPAC meeting, and I know there is a very strong pediatric surgery group in Cairo, and you do a lot of esophageal atresia repair cases. So, and I'm going to share my screen. I want to make sure that you're able to see the presentation mode. Please tell me.
Yes.
Okay. So, as I already said, thank you so much for this opportunity. This is a very important topic and very close to my heart. And every pediatric surgeon always got a special feeling when has to manage a patient with esophageal atresia and tracheoesophageal fistula. I don't think I need to really say too much about what esophageal atresia is. Everybody knows probably on this conference, roughly speaking, is a problem in the development of the esophagus that lead to a gap, and sometimes there is a fistula associated with that. In my mind, I think is really important to know the gross classification, mainly because this is going to give us a lot of information about the physiology of the disease that we are treating, and to anticipate which kind of problem we may have with the patient, and to understand what is the management. In this presentation, we are not going to speak a lot about the type A. This is a H-type fistula that we can consider even a different topic, but historically has been always put together with the esophageal atresia classification. I would like just to highlight a few things about this picture, that the most common type is the type C. I never understand why they label type C if it's the most common one, and they didn't put at the beginning of the classification, but this is just another question. So it's important to highlight that in the most common type, this is the physiology that we have. The blue arrows, they are basically showing the flow of the hair, and the red arrow basically where the food could go. I would also highlight one thing, that in the type A and type B, where we have no fistula or upper pouch fistula, the stomach is pretty small, and this is important for a couple of slides later that I'm going to show up. And these two types, when we had to deal with this, most of the time is what we call a long gap esophageal atresia that has got some peculiarity in terms of management. In terms of possible breathing issue, from a neonatology point of view, it's crucial to know if there is a fistula and where is the fistula. So let's move to the next slide. So in terms of incidence, depends from which paper you take the number, but it's normally 1 in 3,000 or 1 in 3,500 live births. We still do not know why we have esophageal atresia, multifactorial. They might have some genetic component for sure, but what we know for sure is that most of these cases can come with associated anomalies. The most common group of anomalies is the Vactor, but it's not the only one. There is also the Charge syndrome. There are other anomalies that are out of this list. But this is important from a management point of view, because we need also to keep in mind, always to keep in mind that when we have a neonate with one anomaly, we have to screen for others. For the management of esophageal atresia, it's very important to do a spine X-ray and a spine ultrasound. The spine ultrasound possible before 4 months of age, because this might show the X-ray, of course, some vertebral anomaly. You may have some theta cording that you can pick it up at the ultrasound. And if you do this investigation before 4 months, you might save an MRI and a possible sedation or general anesthesia. Of course, anorectal malformation can come along with esophageal atresia. Cardiac anomaly, very important. This is probably the most common associated anomaly with esophageal atresia. And from a surgical point of view, it's and the anesthesia point of view, is important to know if you got major anomaly. It's also important to ask the cardiology about the aortic arch. Especially for a surgeon, it's important to know if we got an aortic arch on the right side or is got a normal anatomy. So, and after I will speak about surgically what to do, and I will be happy to discuss also with the pediatric surgeon on the conference what they do with the right aortic arch, plus urology anomalies and LIBS anomalies. This is important also to plan and to involve different teams in the management of our patient. Clinical presentation. So it's typically you have a significant chaloria. You got a patient that is not able to tolerate feeding. You got respiratory issue. You can have cyanosis, as shows in this picture. These are all red flags that had to switch our mind, put down an NG tube and think about an esophageal atresia. For the diagnosis of esophageal atresia, we don't need fancy things. All we need is to put down an NG and get a chest X-ray. And when we have this kind of picture, the diagnosis is done. You don't need MRI, CT scan. You don't need, normally you don't need contrast. And this is already basically give us the information that we need. In this particular X-ray, we see that there is air into the abdomen. So we got already the information that this patient probably is a type C. We have a tracheoesophageal fistula. Potentially can still be a type D, where we have a tracheoesophageal fistula with the upper pouch and with the lower esophagus too. But this is already going to give you a lot of that about the gap too. Normally, these kind of cases are a short gap. Normally, you should be able to repair this primarily without too many issues. About the vascular workup, this should never limit the time to go to the OR. The most important thing that we need pre-op is probably only the echocardiogram, as I told you before, about to know about major cardiac anomaly and about the anatomy of the aortic arch. Sometimes if the cardiology, you might want to be more comfortable, it might ask also for a CT angio to rule it out completely vascular anomalies. All the rest, the ultrasound for kidney anomalies, the spine X-ray, the spine ultrasound has to be done, but can be done in 3-4 days. That don't need to be done pre-op. So I want to spend a few words about antenatal diagnosis of esophageal atresia, because this is gonna orientate us already towards the management and which kind of type of esophageal atresia we may have to deal with. So it's not common performing esophageal atresia diagnosis antenatally. We may have indirect sign. We may have polydramnios associated with this. Another sign is the absence of the gastric bubble. And this, if we go back to the gross classification, is already give us some indication of which anomaly we have. When we don't have a gastric bubble, can be only type A, type B. Cannot be any other esophageal atresia. This is already give you the idea that probably we're dealing with a difficult case, with a long gap, with a small stomach, something that probably antenatally with the counseling we want also to explain to the parents. The other form, in these other forms, you may or may not have some polydramnio. So these are the forms that you very rarely you're gonna diagnose antenatally, and you might have a postnatal diagnosis. Pre-op management, very briefly, is basically supporting management. We need to control the secretion. And so what we use, the replugger tube is the device that we use in our unit, is roughly speaking, is a particular kind of tube with two lumen, one for the suction, one for the flashing. The main difference with a normal NG tube is that you do not have the vacuum effect towards the esophageal mucosa that in my injury, the upper pouch, and that is going to reduce the chance of injury and optimize the suctioning effect. Normally, actually, I would say always never, and when happens means that we're in trouble. You don't need to intubate this patient. If you're able to manage the secretion, the patient should be in room air without any intubation, without any positive pressure possible. Because when we get there from an neonatology point of view, surgeons start to be really worried, and I got a case later that I will discuss to make an important point at the end of the presentation. Of course, we discuss supporting like with fluid, echocardio, if very important pre-op. All the rest is secondary at this time. Now, I want to go on the part that I like more, surgical management. And I know that in Cairo, you do a lot of thoracoscopy repair. That I think is the way to go. And I will spend a few words also about long gap versus non-long gap. So let's speak about thoracoscopy versus open approach. Let me say something. At the end of the day, the important thing is to do a good operation for the patient. So if your surgeon is a good open surgeon and feel comfortable to do a good job with an open approach, it's fine. If they are more comfortable to do a thoracoscopy, I think that is going to be in the long term the gold standard, and is my personal preferred choice. The main advantage that I think we have with thoracoscopy, sounds silly, but it's definitely the view. The view is amazing. You can compare this two picture. On the left side, we have a thoracotomy, the normal we do in the 5th, 4th intercostal space. When I was a trainee and assisting, I couldn't see anything. Probably the operator, you got a complex case, and the operator is the only one that really can see something. Here you have the azygos vein, that is a good landmark to identify the tracheoesophageal fistula. Under this surgical instrument, you might start to see what we think is the tracheoesophageal fistula, but a lot has to be clean and prepared. The view is definitely suboptimal. I think the great advantage on the right side, you can see the fantastic view that you can have with a minimal invasive approach. Everything is magnified. Now, I put some label over here, the azygos, the vagus nerve, that is very important to identify the lower pouch, the other important structure, the azygos vein. You always got the fistula going behind the azygos vein, the aorta is over here. So this is a great great view. Of course, requires a different set of skills, but is not a surgery that is impossible to perform. People can be trained in that, they can be very proficient in that. Thoracoscopy is still not the most used approach. I just reported a recent paper from the United States where was a multi-center retrospective and partially prospective review where were involved 11 institutions along long period of time with a significant number of patients, and only 11% of the patients were treated thoracoscopically. However, and this is probably one of the surgeons with the greatest experience in thoracoscopic repair in esophageal atresia, Dariusz Potowski from Poland. He did over 150 cases and is advocated that this is probably the way to go. He allows you also to do very difficult cases, and in my opinion, and it's also how he advocates, is a game changer also for the long gap esophageal atresia. Here I reported a short video that hopefully is going to work, just to give you an idea how good is the view. Of course, it's very easy to identify the structure. You need to be careful with the other section, but normally if you do a good job, it's pretty bloodless, the procedure. I suggest to avoid any monopolar energy in during the dissection, mainly to respect the structure that are in the chest. The space is very narrow, and the vagal nerve is just close over here, this white structure over here that we are stretching out. The aorta and the azygos are there. Another important step that I like to perform before starting an esophageal atresia repair is an intraoperative bronchoscopy. That is important no matter what, if you do a thoracoscopy or open approach. But this is going to give you several information about the anatomy of the tracheoesophageal fistula. So you have, first of all, starting from the top, you can assess for potential laryngeal cleft. That is an anomaly, rare, but you can potentially have in esophageal atresia. You're going to assess for potential tracheomalacia, the severity, the moderate, mild, severe, and have an idea for the future management of the patient. And after, you can rule out if there is an upper fistula with upper pouch and confirm about a lower pouch fistula, and also measure the distance from the carina. And that is very important during the surgical step into the thorax, because if you got like a fistula that is a couple of centimeters above the carina, you can predict that probably should be able to do the anastomosis for this case, because the gap shouldn't be so long. While if you got a fistula that is just inserting at the carina level, that is pretty low, it might be a big issue to perform a primary anastomosis. Long gap. There are several ways to define a long gap. Somebody reported the 4 centimeter. I prefer the 3 vertebral bodies. That definition is a bit more scaled with the patient, and so you don't really care if the patient is 2 kilos or 4 kilos. You don't count the vertebral body. While if you're gonna say is less or more than 4 centimeter, it might be significant in a 2 kilos patient. It might be less significant in a 4 kilos patient, the 4 centimeter. However, I also think, and somebody might laugh about that we have a long gap every time that the surgeon is not able to put together the esophagus, no matter what is the length. However, the usual management of long gap was to perform a gastrostomy, and this is pretty much valid for the tape A and tape B, but you can still have type C with the long gap. We do the gastrostomy, and few months later, you do a gap assessment to see if the gap is reducing, or there are different ways to deal with that I will mention later on. However, recently, somebody started to challenge the use of gastrostomy and start to advocate that you can do a staged thoracoscopic, or anyway, a repair of esophageal atresia without a temporary gastrostomy. In this paper, they reported, I think, 4 cases. What they do, basically, they skip the gastrostomy. They bring the patient day 1 or day 2 of life to the OR. They do the dissection, and they apply traction between the upper and the lower pouch using non-absorbable suture. So that is a sort of Fokker, internal Fokker technique. The difference is that instead to wait, making a gastrostomy wait months sometimes, they, in these 4 cases, they went back 3 or 4 days post-op, And what they found that they set a bit more and they were able to perform the anastomosis. Of course, the anastomosis is going to be under tension. Of course, there's going to be a risk of esophageal stricture, but this is a way basically to speed it up the process and to skip the gastrostomy. Other more classical approaches is, as I said, the gap assessment that basically I'm going to show in one of our cases what exactly means, but there is not a real time when to do the gap assessment. You need to have a mature gastrostomy that normally is going to be after 6 weeks from the gastrostomy. So roughly speaking, a gap assessment after 2 or 3 months to see if our pouches are growing and coming together is an option. Another option is Fokker technique that can be internal Fokker or external Fokker, but the concept is to apply traction on the pouch, more or less how in this picture. But you don't go back in a short time, you do a gap assessment and you see if the two edges are going together. This is a bit more easier to do with external Fokker when you got the ties that you put outside the chest and you can progressively apply traction day by day. And if you left a couple of clips into the chest in the upper and the lower pouch, you can assess with chest X-ray if the pouches are coming together. Of course, is not without risk. It's not always without challenges. You might have upper pouch or lower pouch perforation. The traction might be too much, or you might have simply that the two pouches are not stretching out. Last option that is always the last resource is esophageal replacement. I want to stress on the fact that it's always better to keep the esophagus of the patient. That is always the best option. So as pediatric surgeons, we should try to achieve, try to maintain and to keep the esophagus of the patient as much as we can. For esophageal replacement, we have colonic interposition, we have gastric pull-up as technique, that are the two most popular one. Probably a colonic interposition is more from North American in terms of historically speaking. Europe, especially Great Ormond Street, taught a lot about gastric pull-up, but these are very big procedure that as normally have done in big center. I want to mention something about more innovative kind of technique. I don't know if any one of you heard about the magnumosis. This is a innovative technique that reserved mainly for long gap esophageal atresia. We had a small series here in Manitoba that I'm going to mention shortly, and we were the first Canadian center to publish about this option. The concept is very exotic. Here, the summary, you basically put a catheter in the upper pouch with a magnet, and you must have a gastrostomy here, as we normally perform for long gap, and with a gastrostomy tube that has a magnet at the tip, you try to cannulate the lower pouch, and after you hope that there is some sort of attraction, and this attraction is going to work stretching out the pouches until the two magnets are going to touch together, and we are going to have a inflammatory and necrosis kind of anastomosis here that hesitate with the esophageal patency. Very exciting. When I heard about this, I was very excited about that, and we had a couple of difficult cases at our center, and my group published a short series. What we notice with this technique that when works, you always need to perform a lot of esophageal dilatation, 6, 7 at least. So basically, there's a narrowing of the anastomosis that probably due to the tension or due to the necrosis that you create with the magnet. We have a failure that we couldn't do the anastomosis because the pouches didn't move. After this short series, also other groups start to use it in selected cases. There's a sort of limitation. The companies say that the limit is 4 centimeters between the two pouches. So if you got a longer gap than that, the device might not work. In this other center, they manage 5 or 6 patients with this technique. But somebody started to publish also about complication that has been reported. The main one was perforation of the upper pouch. And this basically create a sort of skepticism towards this innovative technique. In Canada right now, we cannot do this anymore. Right now, is not the magnet are not on the market anymore due to the complication that somebody reported. I think this is going under the innovation umbrella. There are other groups that are using different kind of magnets, and I don't know. Only the time will let us know if this is going to be a sustainable option or not. What we learn here in Manitoba, this is always a second option. We do not recommend to approach a patient with magnomosis as primary option, mainly because you're already demanding to perform a lot of esophageal dilatation without any other option. Post-operative management, very quickly, because these are the questions that a lot of neonatologists ask me when we perform this kind of surgery. First of all, I like to tailor-make the management for each patient, because I still think that every patient is unique. We can give some sort of guidelines. So, because we do the anastomosis, a lot depends from how much tension we have and the feeling that we have in the OR. We can speak that ideally you don't want to move the patient immediately. So even if there is a tension-free or low tension anastomosis, a couple of days of intubation, mainly to keep the patient calm, not because there is a lot of evidence for that, is what we suggest. Paralysis put it, but normally is not recommended. The paralysis is something that you might suggest when you got extremely under tension anastomosis. This is something that I learned from the Great Ormond Street experience, and also there is not evidence. It's mainly surgeon feeling, and that you want to keep the neck not hyperextended, and you might paralyze the patient for 5 days, mainly when you got a long upper esophageal tissue that to give you tension. Feeding time, if we leave a transanastomotic tube, 2 to 3 days post-op, you can feed the patient through the tube, not by mouth. And this is something that can be done safely. And after 5 to 7 days, depend from still from surgeon preferences, you might be able to feed the patient orally. Somebody start to advocate not to leave a transanastomotic tube at the end, so at the end of the procedure, which the idea behind that is to reduce as much you can gastroesophageal reflux that might affect your anastomosis. I found a couple of papers about this. I don't think it's common practice among most of the pediatric surgeons. I still like to leave it, not so much about to keep patent my anastomosis, but just to get the chance to feed early the patient in day 2, day 3 post-op. Chest tube is another big topic of discussion. I normally do not leave any chest tube unless I'm worried about a leakage, and this is always a feeling that you have. How good is your anastomosis, and how much tension do you feel you left into the anastomosis? And after more expert surgeon, they might skip the esophagogram because they might have done 100 cases and keep very comfortable, which is fine. I'm still doing an esophagogram day 6, day 7 post-op, mainly to make sure that the patient is not going to have a leak and develop mediastinitis. So a couple of cases. I think Yasser was involved in this. I like to give title to the cases, and double bubble signs of trouble. And this is what we say for duodenal atresia. So this was a patient that I was lucky enough to do also the antenatal counseling about the duodenal atresia. There was polydramnios, double bubble at the antenatal ultrasound. Patient was a twin. We already know that she was going to be a small one with a low birth weight. So everything, the pregnancy went well until delivery. The patient did reasonable birth for the first hour, and after the patient started to have significant shallow urea and secretion at a level that the neonatology weren't able to manage their way anymore. They tried to pass an NG and they were unable to do that. And this is basically the first X-ray here. There is not the NG yet, but you can already see the double bubble and the gastric, the stomach that was pretty big here. So they called me when this patient was 2 or 3 hours old, and they told me, you know this patient, you did antenatal diagnosis and counseling, and we are not able to pass the NG, so we think there is an esophageal atresia too, and we are just intubate the patient. And this is make me run to NICU from my office, because now this is probably not for expert colleague, but for the most junior one, I think you have to remember that every time that an esophageal atresia with tracheoesophageal fistula needs to be intubated is a surgical emergency. I don't know if you can appreciate the difference between this X-ray, that was the first one, and the post-intubation one. You may appreciate that the stomach is already getting bigger, but this is a risk also for patients without duodenal atresia associated with esophageal atresia, mainly because you might develop what is called a hypertension tracheoesophageal fistula. So this is going to create a terrible situation with the patient intubated, with the hair that is going to shift into the stomach. Every time that you got positive pressure is going to just blow up the abdomen, compressing the diaphragm and making the ventilation nearly impossible. So what I did, I booked this patient as E1. Basically, E1 means an emergency that you have to do in an hour. I was able to thoracoscopically to ligate and divide the tracheoesophageal fistula. While I was there, I tried to do the esophageal atresia repair, and the patient, I didn't have any echocardio or any CT angio at that time. There was a beating structure in front of me, and the patient was 2 kilos in weight. I wasn't able to see the tip of the NG tube pushed down by the anesthetist. So I decided to stop. The patient was already much more stable since we managed to ligate the fistula. We stopped and we decided to do a gastrostomy, and we went back 3 days later because we wanted still to deal with the esophageal atresia and finish to repair the duodenal atresia. This time we were able to go there with a CT angio and an echocardio done. The echocardio didn't show any right aortic arch, but there was an aberrant right subclavian artery that was basically just in front of the pouch. However, the second time we were able to identify the upper pouch of the esophagus. We did a significant amount of dissection, but there was like still a good centimeter of gap, even stretching a lot. And so we didn't do the anastomosis. We abandoned the thoracoscopy part. We did a duodenal atresia repair. And after, we just waited. We waited 4 months, sorry. We went back to do a gap assessment. This was amazing that we could see actually during the weeks that we were waiting that the replogal tube was just, initially was at 11 centimeter and after went down to 12 centimeter, 13 centimeter. So we had the feeling that the upper pouch was growing, and we had the confirmation when we did the gap assessment. As you can see over here, basically there is probably less than a vertebra body on the upper and the lower pouch. This metal part over here is a clip. This is mainly for my colleague, pediatric surgeon. I do not use clip to close the fistula. I use normally Prolin. This clip is on the azygos vein because during the operation there was one tie that was getting loose, so I needed to clip one side to prevent a bleeding. But at least give us, even during the X-rays that we did it, an idea where the gap was even before doing the gap assessment. Another case that I think Yasser was involved with these two, and I label like when the impossible happened, because I still have a lot of questions about this case that I cannot answer, and maybe during the discussion we can come up with some ideas. I don't even expect that most of you is going to believe me, to be honest, but we had a 10-day-old boy with no antenatal diagnosis. Patient was fine, 10 baby, born outside our center, went home a couple of days after. Apparently, from what we had, the patient was feeding and growing until he presented days of life in our pediatric emergency with dehydrated, severe electrolytes anomalies, significant respiratory distress. The patient needs to be intubated, brought to our NICU for further investigation. At that point, I wasn't involved for obvious reason until I think it was a nurse in NICU that tried to put down an NG tube and they couldn't. And they, same picture. And I have to be honest with you, at that point, esophageal atresia wasn't my differential, mainly because the patient was 10 days old. I was thinking some fancy stuff, esophageal narrowing or something, a mass in the chest, something weird that I couldn't come up with anything. I remember we were discussing with Yasser, and we said, what should we do? What we should do next? Because this patient now was also intubated, but we said, okay. I remember Yasser said me, Giuseppe, if you had to bet, what will you bet? And I said, if the patient was 1 day old, I would say esophageal atresia. So we decided to do a contrast that normally you don't do this in esophageal atresia, but that was a unique case. And basically this is what we found. It was a blended pouch. So things start to be like more towards esophageal atresia. And in this case, we did our vacuum workup with the echocardio that show a right aortic arch. And we decide, and this is probably we can discuss with the colleagues from pediatric surgery. I decided to go on the left with a thoracoscopic, left thoracoscopic repair of esophageal atresia. We were able to identify the lower pouch pretty easily. We use a small trick. During the bronchoscopy, we left a Fogarty catheter into the fistula, and we were able to see the balloon of the Fogarty that basically labeled the tracheoesophageal fistula, and we did a primary repair successfully. Few more things about complication and long-term outcomes. So, anastomotic leak. This happened really often. 10 to 20% depend from the studies that you look at. Think also about that these numbers are mainly from open surgery. So mainly we need to keep in mind anastomotic leak is a complication that we are going to deal with. Normally, I'm very conservative. It really depends. Always from the feeling that you have about your anastomosis, because if you finish your operation, if you think your anastomosis was a good one, even if you have a leak, must be a small one, cannot be a massive one. So I had a couple of these cases. We were able to manage with conservative management, keeping the NG tube and glycopyrrolate to reduce the secretion, and we do the contrast until close. Some body, even looking in the literature, might found that they suggest to go back very early. So but I think it's always a risk because you might find fragile tissue and so on. So it's not that I don't have experience in going back, and mainly suggest to do this conservatively. Anastomotic stricture is another possible complication that you need to deal with. Normally balloon or buccal dilatation are the solution. Gastroesophageal reflux is another factor. We like to keep on PPI at least for 1 year our patient. I know the evidence is up and down. We can discuss about that too, but it's our normal practice. And there is always the fear, but this is rare, about a recurrent tracheoesophageal fistula. And also, I say every patient with esophageal atresia has got some kind of degree of tracheomalacia. Most of the time is self-resolving, just with the growing of the child and things are getting better. Rarely you need to do a surgical procedure. Historically, the orthopexy was the gold standard. Now, from Boston group few years ago start to advocate about a tracheopexy. But I think this is something that we can discuss with our pediatric surgical colleagues during the discussion, which one to do. I want to stress out probably the most important thing. These can be complex patient. Multidisciplinary approach is advocated. Neonatologist, pediatric surgeon, feeding team is very important to rule it out associated anomaly, mainly because this might need to involve other teams like pediatric urology, for example, and also is going to affect the final outcome of the patient. Normally, a patient with no associated anomaly has got a good outcome in 90–95% of cases. When we have cardiac anomaly, that is going to affect the final results for sure. Thank you very much, and I hope you enjoy the presentation.
Thank you, Professor Giuseppe. We really enjoyed this presentation. Thank you for the nice cases, and the nice discussion would be surely begin now. So we have some questions from the floor. First question regarding type A esophageal atresia. In some cases, you speak about the option of gastrostomy. What would you do for the upper pouch?
Okay, so if we speak about the type A, so we have no fistula.
Yeah.
So my approach, I don't even attempt to go into the chest right now. I don't do like the Poland group. So the Poland group, they're very aggressive. It might be right. It's just they don't have enough evidence yet. So they go into the chest day one and they do the traction. And after they go in a week time post-op, they try to put together. But they publish only 4 cases. Most of the surgeon, as the way I train, we assume that is a long gap. So I do a gastrostomy day one. I don't go into the chest. And when the gastrostomy is mature, normally I do in a couple of months I do a gap assessment. I go to the OR. I do that by myself. This is crucial because radiology, you need to have a feeling about how much you can stretch the pouches, because you might have the false feeling that the gap is a small gap, while you already apply a lot of traction and you might regret when you go to the OR. So it's better that the operator that is doing and managing the patient has to do the gap assessment. What I do, I bring the fluoroscopy to the OR. I use for the lower pouch through the gastrostomy, I use urethra dilator that got a very nice angle to cannulate the lower pouch. And I put a bougie in the upper pouch. And after I get an X-ray without even apply any kind of pressure, just to get a feeling. If that is already giving me that is like a 2 vertebra body, I do another X-ray, and that one that I show, I just apply that tiny bit of tension, and I had like one vertebral body, and I was able basically to go the case I did recently before coming to Ottawa here to do a thoracoscopy. I go back thoracoscopically, and I was able to join together with a bit of tension, but we successfully repaired that.
Sorry, Giuseppe, the question is about the management of the upper push. They mean the secretion. Do you prefer?
Yeah, no, I leave replogal. So replogal tube. The patient has to be in the hospital. Replogal tube that it might be annoying sometimes, but normally the patient is going to stay in NICU. Our nurses are very good. We give instruction, we support them. But the secretion normally we manage with the replogal tube. We try to do sham feeds as much we can to prevent losing oral skills. There are groups, and I think there is a publication from from Stockholm, the Karolinska Institute. They start to manage this kind of patient, sending the patient home with a gastrostomy and with they use a different kind of tube, but the concept is the same one from the replogal tube. They are starting to publish this result. My concern, it's sorry, 1 second. So they start to publish this. My concern is that you take risk to get an aspiration at home, where for what? To basically, to give the comfort to be at home with your kid, but instead to keep the patient for 2 or 3 months, 4 months until you repair in the hospital. I think from a parent's perspective, you might feel you very well, you stay home with your kids, but from a patient perspective and also physician perspective, we have to keep in mind you are dealing with a major anomaly. 3 months into the hospital is nothing compared to the rest of your life. If you are able to manage properly in a safe way, preventing aspiration pneumonia. An aspiration at home, it might be fatal. You might be your parents sleeping, the kids is in the bed, and something happened to the tube. It's something that right now we don't do it. We keep our patient in the hospital. The nurse is there in NICU, and we manage the secretion with the replogal. Do you do the same in Egypt?
Actually, I'm from Tunisia. We do the same than you, and we don't prefer to perform osophagostomy.
No, no, I agree. Split fistula is a old-fashioned kind of procedure. You lose length every time that you do that. Yeah. You're going to lose at least a good centimeter. So, and you're already in a situation where you don't want to lose length. It's an extra step. An extra scar in the neck is a very old-fashioned. I don't think anybody does so often.
And for long gap esophageal atresia, we are performing, technique using thoracotomy and cervicotomy, because with cervical incision we can release all the adhesions and we can gain weight, gain length and perform anastomosis. So this is. I think
it's a good option. I was in Sorrento for the IPEG in July, and there was some discussion about what to do. And somebody came out with a very interesting concept that is the same one that use the Poland group. If you got patient, even half an hour, if you can apply traction on the upper pouch and the lower pouch and stitches and just stretch it, have time to just wait without pushing you, just leaving this traction for an hour even and do nothing. And after you restart to do the dissection, most of the time you are able to do anastomosis under tension. So that I found an interesting concept that I never do it, because when you try, if in a couple of minutes you see that you're stuck, you say, no, this is a long gap. So you don't want to open the pouch, you don't want to mess it up too much. But I found your approach interesting, because I never thought about to do neck approach to really release and that is going to give you at least a good centimeter, and you might be able to have you ever done that and be able to do anastomosis?
Yeah, 3 cases till now.
Interesting.
Yeah, just Giuseppe, because we are short of time, we have many questions, and we'll try to have quick response. The second question is in type C. If baby is born preterm and needs ventilation, do you recommend gastrostomy to decompress the stomach to avoid gastric perforation if baby is not stable for surgery yet?
Okay, this is a difficult question. So. Yeah. The question is, you say the patient is not stable. But yes. The patient is not stable because of the tracheoesophageal fistula. Okay. I do not recommend. So the aim is to close the tracheoesophageal fistula always, yes. As much as you can. As much you can. The gastrostomy can give you the false impression that you are decompressing the patient. It's not enough. You might buy a few seconds because, of course, you make a hole in the stomach and you are decompressed right now. You might buy a bit of time, but you still need to go immediately as soon as possible to close that. So if you ask me, I will probably be not the only one to say that, but I will take the risk to open the chest and close the tracheoesophageal fistula if I can. Agree with you. Because so now I show the video. The first step, even though this patient probably is unstable, but even if you're able to do open or thoracoscopically, if you know what to do, the identification of the tracheoesophageal fistula is pretty quick. And when you are there, you don't need to divide. If you're able to put like a tie around and close, that is already going to stabilize the patient a lot because you don't have the shift of the hair. You might be able even to finish your esophageal tissue repair. So my approach is always to go to the tracheoesophageal fistula in these cases. Okay. The other question is about babies with low birth weight. Should we wait till their weight increase, or we can do the operation regardless of their weight? So you speak about low birth weight. So yeah, patient less than type C less than 2.5 kilos, or even more. So let's put it in this way. Very low birth weight. So very low birth weight is 1.5 for definition. So in my experience, so far here I did 3 cases low birth weight at birth, and did well. I don't think we need to be scared about the weight. If we think something has to be done, If there is an indication, I will approach. People, they also did 900 grams is reported in the literature, thoracoscopically, which we can discuss which approach. The thing is, it's not that if you're going to do open or thoracoscopical, it's going to be more difficult or less difficult. The challenge is the weight of the patient. But if the patient has an esophageal atresia, what you're going to do, there is a tracheoesophageal field with the fistula. So at least you cannot leave the fistula open because you cannot feed the patient because otherwise you're going to get reflux and aspiration pneumonia if you do the gastrostomy only, even if the patient is stable. So the fistula has to be addressed. So of course, it's a discussion with anesthesia, with the neonatologist, but I will attempt. I will attempt the repair. Even with 1.5 kilos, I will attempt the repair. Agree with you also. Another question about the post-operative management. When you start PPI? Day 1 post-op. And if I did anastomosis, so there is very low evidence if PPI really work. Some group say don't do it, somebody they do it. Somebody even worry about leaving a transanastomotic tube, a couple of publications or so, because they say if you keep open the cardiacs, you might have more reflux, which I disagree with that. Anyway, I keep the PPI since day 1 post-op, at least for 6 and 9 months, and after I go very clinically. One of my colleagues is really advocating. There was a paper, a multi-center retrospective study, different country involved, where mainly gastroenterologists that they advocate to do a upper GI endoscopy and biopsy around 1 year old of age to check for esophagitis, and after decided if stop PPI or not, which I think is a bit of an extreme. And there is, of course, there's not a tons of evidence. My approach is 6 months, 9 months till you start basically solid food, and after stop and see what's happened. I start at day one. Do you do the same?
Yes, but we are used to put PPI systematically and see the evolution after.
Okay.
I
think this is a never-ending discussion because I don't think nobody's got the answer.
Yeah.
And it's difficult to do a RCT about PPI versus not PPI with the number of our population. So,
yeah. Giuseppe, it was wonderful. Thank you for all the nice presentation, nice discussion. Unfortunately, we are short of time, so perhaps
my pleasure.
We will review you in other occasions. Thank you so much.
Thank you so much, everybody. It was my pleasure. Thanks.
And we will leave the floor for the other session.
Thank you very much for our speaker. It is my pleasure to introduce our distinguished next speaker, Dr. Ruben Alvaro. Dr.